Welcome to this video on malignant pericardial effusion. This presentation is given by Dr. Ganel Jules, internal medicine scholar at UTAL. Pericardial disease occurs in approximately 10 to 20% of cancer patients. Metastatic cardiac involvement is most common in the epicardium/pericardium at 76%. Interestingly, it can be the first manifestation of an occult cancer. Factors associated with a higher risk of occult cancer include moderate or large effusions and cardiac tamponade. Other factors include effusive constrictive pericarditis, advanced age, obesity, smoking, and the need for hospitalization. This diagram further illustrates the epidemiology of malignant pericardial effusion, its clinical syndromes, associated risk factors for subsequent cancer, and a key message about its mechanical and prognostic role. Malignancy accounts for 40 to 60% of cases. Mechanisms include direct tumor invasion, hematogenous spread, lymphatic spread, and mediastinal lymphatic obstruction. The most common solid tumors are lung cancer, followed by breast cancer, esophageal cancer, and melanoma. Hematologic malignancies include lymphoma and leukemia. Oncological therapy can explain about 60% of cases. Thoracic radiotherapy can cause acute pericarditis, pericardial effusion, or late constrictive pericarditis. Factors increasing the risk of radiotherapy-related issues include a cardiac dose over 40 Gray, high fraction doses, and extensive mediastinal exposure. This infographic details the etiology of malignant pericardial effusion, classifying it into malignancy, oncological therapy, infection, and idiopathic causes. It highlights key points for understanding the origins of the condition. The clinical presentation of malignant pericardial disease can manifest as acute pericarditis, pericardial effusion, cardiac tamponade, or constrictive/effusive-constrictive pericarditis. The key is to evaluate the clinical symptoms and diagnostic findings for accurate diagnosis and management. Diagnostic evaluation involves initial clinical assessment and key diagnostic tests like ECG, chest X-ray, and echocardiogram. Advanced studies, including cardiac CT and MRI, help confirm the diagnosis, determine the extent of the disease, and guide management. The management of pericardial disease in a cancer patient is multifactorial. It considers symptoms, hemodynamic status, etiology, cancer type and stage, prognosis, functional status, and goals of care. This flowchart details the decision-making process for patients with pericardial effusion, focusing on when to intervene based on hemodynamic compromise, and the preferred techniques for drainage and pericardiocentesis. Cardiac tamponade is an oncological emergency requiring urgent drainage. Management strategies include pericardiocentesis guided by echocardiography, prolonged drainage with a catheter, and surgical pericardial window. Prognosis, recurrence, and a multidisciplinary approach are key considerations. Acute pericarditis associated with cancer is managed primarily with NSAIDs and colchicine for symptom relief and prevention of recurrence. Pericarditis associated with immune checkpoint inhibitors requires specific management. Constrictive pericarditis associated with cancer is challenging and often requires surgical pericardiectomy. This table lists commonly used drugs for managing pericarditis, including anti-inflammatory agents like aspirin, ibuprofen, indomethacin, and colchicine. It specifies the dosage, duration, and regimen for tapering based on different therapy lines. Thank you for watching this video on malignant pericardial effusion.